Now I'm happy to introduce our second presentation, the direct support workforce crisis, a multi-pronged approach to recruiting, training, and retraining staff in home and community-based services. And this presentation is being given by Carol Laws, who's an associate clinical professor in disability studies. She's the PI on the Living Well Georgia project and a disability support professional training and assessment. And also I want to introduce
Michaelyn.
Or Mikey, just okay. Michaelyn Wilson, and she is the project coordinator for Living Well Georgia and works collaboratively with Dr. Laws.
Yeah.
With Dr. Laws. And she has a master's degree in education with specialization in training and performance improvement. So I want to welcome Dr. Laws and Ms. Wilson.
Thank you. Thank you. Can you all hear me well enough? Do I need the microphone? I can project typically. So, okay, well, thank you for having us. We're going to talk with you today about a crisis that you may not be aware of at all. And this is related to. Okay. Oh, thank you. Thank you. And this is related to the direct support professional workforce crisis in home and community-based services for adults with developmental disability.
Just click on the screen and do it. So, there we go.
Okay, so I will warn you, our slides are text heavy. We're not going to read all of it. I just want to give you a lot of information since this is being recorded. You can come back and take a look at it if you'd like, but we really want for you to understand the trends and challenges in the direct support workforce who are critical to supporting adults with disabilities in their own homes and community settings, and understand some of the best practices that have come out nationally that we are using within 3 projects that we're going to describe to you, and IHDD's role in leading these interventions here in Georgia. Thank you. So there are nearly 6 million people with intellectual and developmental disabilities who are living in communities of their choosing and require long-term supports and services in order to really live high-quality lives. There's thousands of community-based provider organizations that provide the support for these 6 million people, and about 1 million direct support professionals who deliver these crucial services. This is really just a small percentage of the people that we know need support, as many of them live with families and are unknown to the service system. Oh, sorry. Okay, so one thing to know about this workforce is we have a sense of who they are, but we don't know exactly how many there are because the Department of Labor does not include direct support professional as a standard occupational code. So they're often lumped in with personal care assistants, home health aides, and nursing assistants. And what they do can be medical in nature. They do med administration, they do other health-related functions. But the competencies that are required to support people to live high-quality lives in their communities are much more about supporting employment, teaching life skills, helping people connect into resources. And so this skill set is very different. Next slide. So the DSPs support people with IHDD in home and community-based service settings. Did this work?
Yeah.
And we often think about them as perhaps not very skilled workers. They're often people who are hired with GED or high school level education, but they really are interdisciplinary professionals who do quite a number of really complex skill activities with people in their own homes and communities. They're often full-time, but more often recently, particularly because of the pandemic, we're seeing part-time workers. They can work in a range of settings, including someone's own home or apartment, in a group home, which might serve 4 individuals under one roof, in an institution for community or for an ICFMR, which is a larger scale facility support, or in a day program. What we can see here, and this is from National Court Indicator's last survey in 2022, is that these are poverty level wages that staff are often paid. The range is from about $8 to about $15. The national average is about $13. The overall average is 13, and you can see in Georgia, we are well below that. So we are paying people less than national average for already very low wages. In spite of this, it's one of the fastest growing occupations in the United States. We will have an increased need of about 8 million workers in order to fill the gap in our fields by 2030. And we've known this for a really long time. This is not a new problem. It's been discussed for at least 30 years. We've just failed to really address it, and now we are really at a crisis. Part of the reason that we will need so many new DSPs is because people with disabilities are living longer. Life expectancy has improved because of medical advancements. Population is growing. There are more people with significant support needs who are being brought into the world and are living past birth. Family caregivers are aging. So we have family caregivers who have a large portion of this population who are now seeing what's going to happen when I can no longer care for my loved one. We know that people prefer to live in home and community-based settings, and so we're expanding those services, and that will create demand across service sectors. But this demand doesn't affect supply because Medicaid is our primary funder for home and community-based service, and those provider organizations don't get to set the rates that they pull down from Medicaid at the state level to be able to pay these staff. So this has been a long time coming, but we need to really understand who we're talking about in order to know how to best address these issues. So we know we're talking primarily about women aged 25 to 64. In Georgia, that makes up about 80.3% of our workforce. So we're really heavily investing and relying on these women. About 50% of them are on some kind of public assistance, like SNAP benefits for food insecurity or temporary assistance for needy families if they have children. The median age of a direct support professional is 47. So these are not necessarily young women. These are women who are also aging. About 60% are people of color, and in Georgia, we have about 73% of them are Black or African American women. And growingly, we are relying on immigrants who are coming into our state. Typically, about 30% fall into these other health para-pro categories, but we really need to consider how our immigration policies are affecting this workforce. In our state, and this is data related to voluntary separation, our turnover in 2020. So this was right in the beginning of our pandemic. We know that the national average ranged between 27% and 80% of people left their jobs. In Georgia, we averaged about 50.7%. And 44% was the average per state. So we had more people leaving the work in Georgia. About 77% separated voluntarily. Of those provider organizations that lost 10% or more of their staff, they also saw services decrease by about 45%. So a lot of people lost their services in 2020. We're really seeing that this has not bounced back yet in our state. Vacancy rates, and that's those open job positions that haven't been filled, are sitting at about 17% for part-time jobs and about 14% for full-time. Of those who left, we see the vast majority, or 50% of the turnover, happens within the first year of hire. So we have this constant churn of workers who are being hired by a provider organization, being onboarded and trained, invested in to some extent, and they end up leaving with that within 6 months or within the first year. But we also see that if you can get to, and this is 52% are employed between over 24 months, if you can keep a worker for 2 years, that tends to be a place where they will stay within the organization of hire. Okay, so when DSPs were asked why they leave, they said things that are not surprising given all of these factors. Inadequate pay and benefits. The work is very stressful. They're often insufficiently trained to do the work, and there's a lack of supervisory support and lack of advancement. We know that this turnover costs organizations a lot of money in advertising and recruitment and onboarding. And there's also a lot in indirect costs, including lost productivity and client revenues that are unrecouped. And Historically, organizations have had a really challenging time in recruiting people into this work, primarily because of the wage, but also because people have to work multiple jobs. There is that reliance on public assistance. There's isolation from other workers. They may not have a direct support supervisor with them on site. There can be high rates of injury. It's a very high accountability work where if there's a mistake that's made in a medication error or any type of accident that can happen, that the staff is often held accountable for that. And there's insufficient training and a lack of career path and advancement. Thank you. So a couple things related to background. When talking about the impact of the pandemic, we've learned that the pandemic has really just put the spotlight on all of the issues that we've already known about, but also really highlighted a lot of mental health and stress-related issues that direct support professionals who did work through the pandemic to support people primarily in residential settings reported. So physical and emotional burnout was reported by half. Anxiety by about half of the respondents in a recent survey, sleep difficulties, physical and health complications, and some even reported suicidal ideation. For the people with intellectual and developmental disability receiving support, we also know that they reported feeling less safe, that there were risks to safety as people, perhaps staffing was not available. They had lowered growth and development opportunities because community centers were closed. Everyone was kind of hunkered down for quite a while. And because it's a relation-based profession, people were not making relationships. They weren't building their communities of support, and there were fewer opportunities in general. So there's negative consequences for people with disabilities that are involved in high turnover of staff, including incidents of harm and critical incidents of abuse and neglect, and also challenging behavior have been reported to have been escalated. This has also resulted in longer waiting lists for services. So we have families that have adults who are waiting to receive a waiver to have their loved ones served by a community-based provider organization, and the organizations are not taking referrals for new folks. Families will consider more segregated or institutional settings for care, given the long waits and the lack of services available in their communities. And we also know from the Council on Quality and Leadership, looking at personal outcome measures, that there's lower quality of life when turnover happens, and people report less, that they're less likely to feel safe. They have feel that they're not having the best possible health. They're less likely to feel respected, less likely to participate in community life, and to exercise their rights. A couple drivers of the crisis, so that you understand kind of where we are working, the space we're working in. Again, we have demographic shifts in the United States. Population growth has slowed. There's a lot of retirement of the people who had been doing this work, including baby boomers who saw this as a civil rights and human justice issue. And in general, we see a decrease in the labor force across all service sectors in the United States. People who are in long-term services and supports tend to have an increase in behavior-related challenges. So this has increased since the pandemic. Anxiety disorder has also increased, and mood disorders. The need for round-the-clock supports has increased, and people are preferring smaller support settings. So we need more people to support people more independently and more directly. So here's some things though that, okay, so we also know that the skills needed have really grown. We need people to have an understanding of how to support people in person-centered ways. They need to have the knowledge, skills, and values to bring into the work, but there's no required federal training. So states can really have a wide variety of options in what they post as the floor for how they train these staff. And there's no widely accessible credentialing or certification that's available to this particular workforce. We also know that we are competing for these staff with other sectors in the long-term supports and services sectors. So we have a number of older adults who are over the age of 65. A lot of them are family members who are living at home with an adult with IDD. About 67% of them were over 55 and over 12% were 75 and older. So we're kind of looking at a confluence of supporting both the adult with IDD and the aging family caregiver to keep them at home. And also the DSPs who've done this work are older and they don't want to keep working either. They want to retire too. So they're aging out of the workforce. So we have systems changes also happening at the same time. So we know that people want to stay home with family or with their foster family or a host home. And there's a home and community-based service settings rule that will be taking place next year that requires people to have more choice and autonomy and to value their living space and their right to live in these smaller settings. So the demand for staff and having well-trained staff is really incredibly crucial for the settings rule to be met. We know also that there's a lot of competition with private sector jobs. You can go to Target and get a job for $15 an hour that doesn't have the high risk and accountability that direct support work comes with. And also when benefits are offered by provider organizations, only about 50% of staff are eligible to enroll. Sometimes that's because of their part-time status, sometimes it's because they're not aware, or it could be because they might lose public benefits if they were to enroll in them. And then of course we've had a lot of inflation in recent years, which further eats away at wages, and the dollars just don't stretch as far. All right, these are just common organizational challenges. I won't go through all of them. We've kind of touched on a lot of these already, but in the work that Mikey and I are doing, we're really trying to address some of the factors that happen within the provider organizations that we are working with to help mitigate some of these factors. And I think I have one more, and Mikey can go. Okay, so there's a number of promising practices nationally that we have become aware of. One of the primary foundational levels that has been developed is an understanding of what the competency sets are that these direct support professionals need to have. And the most recent one came from the Center for Medicaid and Medicare Studies, who is a primary funder of these services in 2019, where they've identified 12 different areas, and under each are specific skill statements that are observable that can be used for job descriptions and performance evaluation and for training. So we have this nationally validated set that we now can use in order to make sure that DSPs are receiving training that is valuable and relevant to the work that they are doing on the job. And so we are using this to build the knowledge, skills, and values that the direct support workforce needs. There's been a few studies that have come out recently that show that the use of competency-based training and mentoring can really help reduce that turnover in staff fairly significantly, and that people with disabilities can receive improvements in employment, social relations, inclusion, and health and safety. And these can be built into state Medicaid plans. One of the platforms that we're using currently is the College of Direct Support, or the College of Frontline Supervision and Management, through a suite called Direct Course. This is all competency-based training that we are leveraging within the Living Well project that Mikey will tell you more about. But all of this can be brought to help stabilize the workforce. And credentialing. So as I mentioned, there's no accredited credential for direct support professionals. There are for CNAs and home health aides. So we really need to develop this out so that there's not only training and the assessment of skill and knowledge on the job, but a career path and coordination with state reimbursement rates to really raise those wages based on professional advancement within this workforce, and create a career ladder that keeps people in the field on the job, but gives them opportunities to advance and to earn more money along the way. And then this is really just more about how this creates career paths and can help people stay in the field, enhance the status, and improve retention rates. And this is really leading into what we do in the Living Well project.
Okay, so the goal of the Living Well project is to develop a model that demonstrates how innovative interventions at that direct support level can improve the quality of supports and outcomes for those who are being supported across HCBS settings. So a couple of the outcomes we have, the staff that are participating, they're going to gain knowledge and skill in supporting informed decision making. The providers will demonstrate an increased ability to retain and develop their staff. An HCBS Quality Enhancement Advisory Council is developed and supported. And then the provider organizations will report increased ability to understand, respond to trends and incident reports that hinder quality. And then lastly, people with IDD that are receiving supports will demonstrate increased achievement of their personal goals.
Roll it down one. Roll it.
So just really quickly from this, we'll go over some of the interventions that we use. The first is Thera. This is a platform that captures service documentation. So it does tracking, reporting, and record keeping, and it's all in a web-based system. And then Carol had mentioned the College of Direct Support. We call it CDS, so you see that throughout all of our stuff. And that is our online learning management system. And then we do in-person trainings with quotations because they were once in person since the pandemic. Now we have a mix of virtual and in person. So the first one is supporting informed decision-making, and then supporting social roles. And then lastly, the code of ethics training, which we adopted from the National Alliance of Direct Support Professionals. Also, they do get an NADSP membership. So with this membership, they get access to webinars, online trainings, and then they also have an NADSP annual conference that DSPs can go to. So we are partnered with 5 provider organizations across Georgia. They have different things that they specialize in. So some are day services, residential, some are very heavily focused on employment supports, things like that. So the College of Direct Support, we created 3 tracks. I could talk about them for a long time. I'll be as quick as I can. The first is a frontline supervisor track. It is courses specifically for supervisors. Then we developed a new hire track, and it does follow the state requirements for pre-service and first 60-day requirements and training. And that is for all DSPs across the state of Georgia. And then we developed an existing staff track for staff that have been there for years and maybe just need some refresher trainings. An important thing to know, all of our providers can develop any module they want. They can go in and pull what is important to them, what they think is relevant. So they have freedom aside from what we've developed. So pre-COVID, we had 247 learners. The total number of lessons assigned was 7,628. And the total number completed was 4,554. Of course, we would love for that number to be higher, but then came the pandemic, which really interfered with the staff being able to complete their lessons. And also in each lesson, they do a pre-test and a post-test. So we're able to see knowledge before they review the content and then knowledge after. And our in-person training, so this we do with Tracy as well. So the first is the supporting informed decision-making. We've had 121 learners. We do an evaluation at the end of each training where we do track their knowledge before the training and then their knowledge after the training. So we also do the supporting social roles training, which does have less, that has 33. We did develop that training in year 1, started it in year 2, and then the pandemic. So that number is significantly lower. I did mention the NADSP memberships. We have had 20 DSPs. The first 2 years we went to St. Louis. I can't remember where we went the second year, Columbus. But we had 20 DSPs and frontline supervisors from our providers attend. It was great. Most of them had never been on a plane. Some had never left the state of Georgia. So it was a really great opportunity for each of them. They've been virtual the past few years, but the next one is in person. So we get an opportunity to send them again. And as it relates to Thera, so our providers are able to go in and put all this information into this system. One of the most important things that they get to do is put in incident reports, and then they get to aggregate that data. So they get to look for trends in the data. So for example, you can see in 2019, we had a huge jump in incidents. They can go in and they can pull the time of the incidents, the location, what staff is involved, so they can really dive in and figure out what's the problem and how can we fix it. Then they have access to CDS, so they can create modules for staff that maybe need some further education in certain areas so we can really reduce these incidents. Another thing we developed, so in therapy, you have data-driven outcomes. So this maps the individual service plan goals and progress notes to aggregated domains. And so we developed 5. Those are choice, meaningful activities, person-centered practices, safety, health, and well-being, and then social connectedness and relationships. And then we further divided that out and we did, is this goal important to the person being supported, or is it important for? And we pretty much see most of them are important for the person because they're written by support coordination. So it's other people writing those goals for them, even though they're involved. And then we look at those and we say, was that goal achieved? Was it not achieved? Or is that goal in progress? So you get to look and see the fluctuation and you get to really dive down and ask why are goals not being achieved, things like that. And then because we've done all of these interventions and we're tracking all of these numbers, we started doing staff comparisons. So on this example, you can look at staff number 4, you can see their DSP, and we get to pull all of their data from 2020, 2021, and 2022. And we get to see in that first red circle how that achieved, that percentage has grown. And you get to also see what in-person trainings they've attended and how many courses they've taken on the College of Direct Support. So we get a real-time look at goal achievement for those who are participating in our interventions. Okay, so we'll kind of switch gears out of living well. I know I'm talking really fast, I don't want to run out of time. We talked about some of the challenges of that this workforce, and because of the amount of money and salary and things like that, a lot of needs are there, and a lot of those needs aren't met. So this is a pretty long list, but for example, there's transportation assistance, maybe just education on how to lower your internet bill, things like this that maybe a lot of people in this field don't know. So one of the things that we are working on, this is a grant that we got and started in March of 2022. It's called DSP Innovation, and it's developing an employee resource network for direct support professionals in Georgia. So basically what we're doing is we are creating a guide and trying to show the state of Georgia how to create employee resource networks, otherwise called ERNs. So this is when a group of providers in a similar geographical area, they get together and they create this network. And they hire a success coach that comes in and can help with the DSPs. And they can provide resources for DSPs because one provider alone doesn't really have the resources to do that. But when you get several providers together, they're more able to provide those resources to that. So we have done our research in this, we have identified specific needs in Georgia, and we're currently creating a guide to implement ERNs in the state of Georgia. And then the American Rescue Plan Act of 2021, also called ARPA, this provided temporary funding, and this is to incentivize staff recruitment and retention. So this is another thing that we are working on. Do you want to go ahead and go to the next slide? So we're in the Georgia DSP Workforce Work Group. Not the most creative name, but it's fine. We began meeting in January of 2022. We meet every other week through WebEx. So what we're currently doing is exploring best practices in workforce development. We're looking at existing options and new evidence-based interventions to really address the gaps and improve recruitment and retention for DSPs in Georgia. So what we're currently working on, Carol and I are about to start really diving into this in January, but this is the Disability Support Professional Assessment Program, also called DSP TAP. So the goal is to develop the first replicable and scalable nationally accredited training and standardized exam and assessment process for direct support professionals. So we really want to get this accredited, and we are going to do that through ICE, the Institute for Credentialing Excellence, and also through NCCA. So another big component of this is online training, so we can develop a pathway to that credentialing exam. So yeah, I think we did it in 25 minutes.